As we conclude our antepartum unit, we will now be discussing surveillance of fetal well-being during the antepartum period of time. Chapter 15 covers the prenatal diagnostic tests that pregnant women may be involved in during their pregnancy. The learning goals for this chapter are to identify indications for fetal prenatal testing, discuss the purpose, the procedure, the advantages, risk factors of each of the diagnostic tests that we're going to discuss, to relate the patient teaching and answers to common questions for each of the prenatal diagnostic tests that will be discussed. There may be some other tests that are in the textbook chapter, but they are not going to be testable material. So let's take a look at who should have prenatal diagnostic testing and why it would be done. Some tests that we do today routinely in the past have been used for clients or patients who were high risk, but tests such as the alpha-fetoprotein and ultrasound are now done, or at least offered to every pregnant woman regardless of her risk. In general, indications for prenatal diagnostic testing are in order to detect congenital anomalies of the fetus, to evaluate the fetus's well-being in a high-risk pregnancy, and to provide us some baseline information for more accurate gestational age assessments when that is called for. More specifically, we want to use some of these prenatal diagnostic tests for patients who have certain medical conditions, such as diabetes, whether it be gestational or pre-existing, if they have chronic or preeclampsia, chronic hypertension or preeclampsia, if they have any sexually transmitted diseases or infections, if they have anemia, if they have a genetic disorder. Demographic factors, of course, would be related to their age and their socioeconomic status, as well as their inability to access prenatal care. Obstetric factors would include any previous history of a fetus that was born prematurely or low birth weight, in also multifetal pregnancies and presentations. And concurrent maternal factors are those that we are seeing increasingly more common. So those are with women who have high body mass indexes, who have weight problems in general, whether it be too much or too little, and the use of substances. So there are quite a lot of women who fit the category of patients who we want to screen, regardless of just the general need of knowledge. Types of surveillance that we're going to be discussing are ultrasound, alpha-fetoprotein screening, chorionic villus sampling, CVS, but not the drugstore, amniocentesis, non-stress testing or an NST, and the use of vibroacoustic stimulation during that test if necessary, contraction stress test, which is abbreviated CST, or OCT for oxytocin challenge test. If you should see those words or phrases, they're the same thing: contraction stress test and oxytocin challenge test. Biophysical profile, or a BPP, is very common. And then finally, maternal assessment of fetal movement. Again, if there are other tests in the chapter of the textbook, we will not be covering those for this exam. We see ultrasounds performed two different ways in pregnancy: the transvaginal route and the transabdominal way. Transvaginal ultrasounds are usually reserved for when the uterus remains in the pelvis. And so that's prior to how many weeks? That's right. In the first 12 weeks, the uterus remains as a pelvic organ before it pops up into the abdomen and becomes an abdominal organ. In addition to the first trimester, we may see transvaginal ultrasounds used later in pregnancy to evaluate the cervix for length in terms of diagnosing preterm labor. Otherwise, during the pregnancy, the transabdominal route would be preferred. There are some advantages and disadvantages to ultrasound. Very clear visualization of the fetus and structures. And gosh, if you've seen 3 and 4D ultrasounds, they're absolutely amazing. They are considered safe. Many call ultrasound in pregnancy non-invasive. For those of you or us who have experienced transvaginal ultrasounds, in fact, they are invasive. Not necessarily painful, but they are invasive. We can get immediate results, but that really depends on who's performing the ultrasound. Only a person who can develop a plan of treatment can give test results, unless given permission to by the healthcare provider. So an ultrasonographer cannot give results unless they have explicit instructions from the healthcare provider to do so. By law, it is outside of the scope of the practice of an ultrasonographer or a nurse, because neither person can give a plan of treatment based on those results. However, in private practices especially, many times the ultrasonographers are giving the results. I know I used to when I would do it, not only as a nurse practitioner, but as the sonographer as well. Immediate results are good. Nobody wants to go home and wait to be called later today or tomorrow with those results. Disadvantages include that sometimes every structure and every problem cannot be seen. They can be very clear pictures, and you can see the chambers of the heart and the heart beating. You can see swallowing, and you can see the fluid in the brain and bowels moving and bladders filling up. However, sometimes we miss things. As they get older in the pregnancy, farther along in gestation, they can be less accurate, in particular for the gestational age and more particularly for weight. There are some cost concerns. These are not free or inexpensive, and generally insurance companies want to have a reason in order to perform an ultrasound. A 20-week ultrasound, as we've discussed in class, is a wonderful time to do one because all of the anatomical structures are formed by that time and clearly identifiable. Although we know many of our patients and clients want to use it for the gender reveal. But cost concerns are definitely there. And it can cause prenatal anxiety on the part of the parents. That usually is more so if it's not an immediate process. So if you're in the physician's office and they recommend you have one, they bring the machine in, or you go to the next room, you get it, you get the results, I'd say there's not much time for anxiety. But if you have to schedule an appointment and wait a day or 4 or 5 hours and then wait several hours more to get the results, that can cause, of course, a lot of anxiety on the part of the parents. We can use ultrasound for different purposes in the first and the second and the third trimester. In the first trimester, we're primarily looking for the location of a pregnancy, whether it be in the uterus or outside of the uterus. If it's very early in the pregnancy, we may not be able to see it in the uterus, but at a certain level of beta HCG, which you don't need to know, but is about 2000, you should be able to see a gestational sac inside the uterus. And if you don't, then we begin looking outside the uterus and the tubes and the cervix and other places. And whether we can see it or not, we know that there's a pregnancy most likely there. We can also use this transvaginal in the beginning to confirm viability of a fetus. So a woman who comes into the clinic, the triage, or the ED with vaginal bleeding and suspected or actual pregnancy, then we can use the transvaginal ultrasound to confirm not only that there is a pregnancy in the uterus, but that it is viable, meaning that it has a gestational sac and maybe a yolk sac in that, and we should be able to even see a heartbeat in the embryo when the embryo itself is only about 5 millimeters long, but we can see a flickering or a bleeding of the beating of the heart. Is absolutely a miracle and amazing, actually. So those are the most common reasons. In addition to, we use ultrasound during the procedures for chorionic villi sampling and amniocentesis. During the second and third trimester, ultrasound is also used for confirming fetal viability. Again, looking at all the anatomy and functioning organs of the fetus, as well as looking for the placenta and checking for whether it has any bleeding or any abnormalities. We also look at the amniotic fluid during the second and third trimester as part of a biophysical profile. Presentation of the fetus can be confirmed from vertex to breech presentation, which may direct the method of delivery. We can do that in the second and third trimester as well. There are more details on ultrasounds and the purposes of ultrasounds on page 303 in your McKinney textbook. Alpha-fetoprotein is a screening test. It's a screening test that primarily can screen for Down syndrome as well as neural tube defects. Note I said this is a screening. If this test comes back abnormal in any way, it needs to have further confirmation that an anomaly actually exists. That probably would be in the form of an ultrasound. Could be an amniocentesis as well. So we collect alpha-fetoprotein either from the maternal serum, so it's just a blood draw, or we can collect it at the time we're doing an amniocentesis utilizing the amniotic fluid. Alpha-fetoprotein is a protein that's found in fetal plasma. It diffuses from the fetus and is excreted into the urine. And once that happens, some of the alpha-fetoprotein crosses the placental membrane and then enters the maternal circulation. That's why we can pick it up both in amniotic fluid, because it's urinated there from the fetus, and also we can pick it up in maternal serum because it's absorbed then through the placenta. Very important for the timing to be correct on this. In fact, when we get an abnormal alpha-fetoprotein back from the lab, the very first thing we do is confirm gestational age. This is when you'll run into those women who didn't really know their LMP but kind of made it up. Very important, of course, as we've discussed, to not do that. Also, weight can be dependent because how the alpha-fetoprotein is diffused in the body and therefore the vascular system of the mother after it crosses the placenta is different in women who are obese than women who are not. So those are things that we're going to be considering if we get the abnormal results back. A couple of things that I want you to remember only about the results is that when we have low levels of maternal serum alpha-fetoprotein, so MSAFP, sometimes you see it written as like that, sometimes you see alpha-fetoprotein or AFP. Either way is correct. So the results that I really want you to be familiar with are if we get a result that is low, that goes for Down syndrome. So low equals down. Low equals Down syndrome. Again, remember, it's screening, not diagnostic. The other way, if it's high, it's the other condition that we're concerned with. And as I mentioned before, that's neural tube defects. So a low result is down or downs. The opposite of that, high, is the other condition, neural tube defect, which is what we can detect. Again, a screening test, so once an abnormal result is obtained, clarification on weight of the mother and her age in gestational weeks is confirmed and then followed up with further testing, probably an ultrasound. Chorionic villus sampling, or CVS, is a test that's done approximately 10 to 13 weeks of gestation. And the purpose of this test is to detect any fetal chromosomal or metabolic abnormalities. That's an advantage of doing it early. The biggest advantage of the CVS is conducting it early in the pregnancy. Why is that an advantage? Because if a person, a patient, a client, a couple decides to terminate a pregnancy based on the results of the CVS done between 10 and 13 weeks, it's easier physically and emotionally on the woman's body and mind to do so. Now, keep in mind these results take about 2 weeks to get back. So if we're doing it between 10 and 13 weeks, the results will be back between 12 and 15 weeks. And so terminating a pregnancy at that time is easier than terminating a pregnancy, let's say from results from an amniocentesis, which might be as late as 15 to 20 weeks and receiving the results at 17 to 22 weeks. So that's the primary advantage. The obvious disadvantage is that it only detects chromosomal and metabolic abnormalities. It does not detect any abnormalities that involves the amniotic fluid, so it would not show up any abnormalities of a neural tube defect. It also would not give us any information about an abdominal wall abnormality such as gastroschisis, where the intestines are born on the outside of the body cavity. So that's a real disadvantage. So in addition to getting results early, one would have to consider what is the primary purpose of doing this test. If this is a patient who's had a previous trisomy 21, and regardless of how that pregnancy ended up, if they want early screening, whether that's going to affect this pregnancy or not, this would be a perfect test for that because that's a chromosomal abnormality. If they've had something that had to do with neural tube or gastroschisis in the past, that type of defect, this would not be the best choice for them. And so that is the primary reason for choosing a CVS over an amniocentesis, because it can be done earlier. So termination is easier emotionally and physically for the mother, and also that the results are really related to chromosomal and metabolic abnormalities. And so if that's the patient's primary area of concern, this would be a test for that. You can see that during this procedure, an ultrasound on the abdomen is used, and we do that in order to locate the placenta, which is right here, and the fetus, which is right here, because clearly we do not want to be poking either one of those organs. So we use this device here that is inserted via a speculum that you don't see, but it is, through the vagina, into the cervix, and then up to the membrane, the chorionic membrane, and collecting some little snippets of tissue there from the villi of the chorionic membrane. Now, is the chorionic membrane the membrane that's farthest or closest to the fetus? That's right, it's the farthest. The best way to remember that, if you have trouble remembering it, is that the amniotic membrane and the chorionic membrane make up what's called the bag of waters. The amniotic membrane is closest to the amniotic fluid, which is, of course, surrounding the fetus. So the amnion is the closest to the fetus. The chorion is the part of the bag of waters that's on the outside. So these little tissues or snippets of this villi then are sent to the lab. Cells are grown and extracted, and then DNA karyotypes are produced. But again, we're only getting metabolic and chromosomal abnormalities here. We're not getting anything about neural tube defect. Again, that's the big disadvantage. Amniocentesis is similar to a chorionic villi sampling in that we're going to extract some material from the pregnancy, send that to the lab, and grow cells, and then do a DNA karyotype on that. So the similarity is that an ultrasound abdominally is used, and in this case, again, we're identifying the placenta and the fetus, but at this time we're not looking for chorionic villi for sampling, we're looking for amniotic fluid, which is right here. So the sonographer will identify an area of fluid. Then the area will be numbed up by the healthcare provider, and then a very large syringe and needle will be, the needle of course, will be injected into that pocket of fluid, and they like to extract about 20 to 30 milliliters of fluid. Amniotic fluid should look clear maybe yellow or straw colored. It should not be green or black or bloody or anything like that. So in this case, we're not taking the chorionic villi again, we're taking amniotic fluid. But the process when they get to the lab is similar. They take that fluid, and one of the things that they do with it is they grow some cells, take the cells and extract the DNA and look at that for abnormalities. There are other hormonal tests that can be done as well, and we won't worry too much about those, but they can also pick up other abnormalities. Now, on an ultrasound, I can't remember if I've told you this before, but on an ultrasound, fluid is black. So anything that's liquid is going to look black. So in this case, the amniotic fluid in here looks relatively black. Anything else in this relative area look black to you that we would not want to mistake for amniotic fluid? Exactly. Here is the bladder, and the fluid in the bladder appears black or dark in color. So we want to make sure that before a woman has an amniocentesis, we assist her to void to empty her bladder, because we do not want the urine in the bladder to confuse us on an ultrasound and think that that's where the pocket of fluid is in the uterine cavity. So very important to have the woman void prior to her procedure. So the 2 times we do an amniocentesis in OB, in pregnancy, the first time is in the 2nd trimester, and this is for fetal health. So we'll talk about that in just a moment. We kind of already have. The 2nd time is in the 3rd trimester, and we're not looking for fetal health, although we are still looking at the fetus, but we're looking for maturity, fetal maturity, such as fetal lung maturity. So the big deal about understanding that these are done at 2 different times are that the results will be available at a different time and different results. So the procedure for both are exactly the same. An abdominal ultrasound is done to identify the location of the fetus and the placenta. The needle is inserted into the uterine cavity, and 20 to 30 milliliters of amniotic fluid are withdrawn. But then what happens to that fluid afterwards and what tests we're going to do on it depend on whether we are looking for health or maturity. So in the 1st trimester, usually between 15 and 20 weeks, and probably even more between 15 and 17 weeks when an amnio is done, we're looking for genetic analysis. We're really looking for congenital anomalies such as trisomies and anything DNA related or even metabolic, and including neural tube defect. Note that with the CVS, we did not include that, but with amnio we do. The 2nd time in the 3rd trimester, we're looking for fetal maturity, in particular fetal lung maturity. So we're doing a couple of different things with the fluid that we're not doing when we're sending the amniotic fluid for the genetic analysis. We're going to send this fluid looking for a couple of different test results. The first one is an LS ratio. That stands for 2 lipoproteins that are components of surfactant. Those are fun words to say once you learn to say them. It's lecithin and sphingomyelin. Throw those around at a party and people will be so impressed with you. Just kidding, of course. So what we're looking for is the ratio of lecithin to sphingomyelin. Generally, we're looking for a ratio of at least 2 to 1. And what that means is when we get a ratio that's greater than 2 to 1, so not equal to, forgive me for saying that, but greater than 2 to 1, that means that the surfactant is probably adequate enough so that the lungs are mature. Surfactant, if you don't remember, is that material in the fetal lungs that not only allows them to expand with inhalation, but then to also collapse so that they can open and close and open and close. Makes them very flexible. That's not exactly the word I'm looking for, but flexible. Okay, so we want an LS ratio of greater than 2:1. Now, it's not a guarantee that this child will not need some ventilation assistance upon birth, but it gives us a good idea. The other tests we're looking for are PG and PI, and those are phosphatidylglycerol and phospho something something, which I can never remember. Those are phospholipids that boost the properties of lecithin. So lecithin precedes surfactant, and PG and PI come before lecithin. So all related to fetal lung maturity. The type of person that we would probably see doing a third trimester amnio for fetal lung development might be a mom or a fetus who are having some compromise in utero during the pregnancy, but they're early and we don't necessarily want to deliver them early. Remember the basic concept of always the best incubator in the world is not located in the NICU. The best incubator in the world is located in mom's body called the uterus. At any point, however, if that uterus begins to not be the best incubator, we will remove the fetus. Sometimes we have an option of waiting a few days before we induce or deliver by cesarean, so we can have some time to see, are their lungs mature? Now, the test results for both of these, as I mentioned, are very, very different in terms of how long it takes to get them back. With the second semester trimester for fetal health and genetic analysis, that takes about 7 to 10 business days, so about 2 weeks to get those results. The third trimester for fetal maturity in a tertiary care center that has an OB department, it only takes about an hour to get those results back. So you can see how it would be very important for patient teaching for you to know how long it took for each one of those to get back. Because if you told a mom for fetal maturity that it's going to take 2 weeks to get back, they're really not going to understand that. And if you tell a mom or parents who are waiting for their second trimester genetic analysis that it will be back in an hour and it's 2 weeks, you've caused them probably a great deal of angst. So the time frame of receiving the results are very important. Again, the results would be shared with the patient by the healthcare provider unless the registered nurse has been instructed or asked to be shared with the patient by the healthcare provider. What I neglected to mention on the CVS is that there is a loss with both of these procedures, a potential loss of the total pregnancy. The loss of or spontaneous abortion with amniocentesis following that is usually less than 1%, so about 0.5%. So out of 100 women, right, less than one of those would experience a spontaneous abortion just because you stuck a needle into the uterus and made it irritable and then they proceeded to deliver. The risk is a little bit higher with a chorionic villus sampling. It's about 2.5% pregnancy loss. So there is that piece also to consider when a client and a couple are deciding which one of those procedures that they would like to proceed with. Both, as you can see, are relatively safe, but it depends on whether the risk for that particular couple outweighs or not the desire for the information. So I think we've discussed before, some patients don't want these tests regardless of the loss because they have no intention of terminating their pregnancy. So for them, they may get ultrasounds later, but these potential losses wouldn't concern them because they're not going to do it anyway. So this is just a picture again of the procedure of an amnio. Just as with the CVS, very important to have our patient void and empty their bladder of urine because again, the urine in their bladder is going to look black, and on a real ultrasound picture, so does the amniotic fluid here. Now what's missing in this picture to make it accurate, of course, is the ultrasound, okay? The ultrasound that's locating the fetus, locating the placenta, as well as locating the amniotic fluid, okay? So very important, again, to empty the bladder. And then that fluid, of course, will be taken to the laboratory, and then a karyotype will be produced. Another prenatal test where we can assess the status of the fetus is a non-stress test. This is a very, very common test. It's easy to do. It doesn't take very long. It's not terribly expensive, and it provides quite a bit of information. The purpose of it is to identify whether the fetus's heart rate changes with activity. So the advantages of an NST are that it's non-invasive. The procedure is that a woman usually sits in a reclining chair and the fetal monitor is applied, so a Doppler for the fetal heart rate is applied in the appropriate location on the abdomen, and also a contraction belt is also applied. Then mom is given a little buzzer or a bell or something that makes a mark on the record when she feels her baby move. So she's instructed to, push that button when the baby moves. And we'll look at some pictures of what that looks like in just a moment. So the advantages are that it's non-invasive, harmless, painless, other than you have to sit still for a few moments, of course, about 20 minutes. It's easy to administer, and it may be repeated multiple times. In high-risk women, who are hospitalized in a high-risk perinatal unit may have an NST every shift. They may have one every day. Just depends on what the condition is. So I can't tell you exactly how often. Again, the results are available immediately. Whether the person who's doing it can reveal those or not will be dependent upon the practice that they're in at that moment. Disadvantages are sometimes there are false positives, which make recommendations by the healthcare provider to proceed with other testing, most usually a biophysical profile, but that causes, of course, angst on the part of the mom and the couple as well. Sometimes we have a difficult time getting an adequate tracing of the fetal heart because the mom's moving or the fetus is moving, etc. And of course, nobody likes to try to remain completely still for 20 to 30 minutes. It sounds easy until you have to do it, and then you kind of get antsy and you want to move around, and sometimes that's okay, but sometimes that's going to affect the ability to get a really clear picture of the fetal heart tracing. So again, this is to determine if the fetal heart rate increases with movement. Now we're going to look at some results on the next page and discuss what those mean and which kind of result we're looking for. So we're looking for the result called reactive. This is the result we want. And this has 2 stars on it because I want you to know this. Memorize it upside down, sideways, backwards, etc. I want you to know what it means to have a reactive NST. Reactive is good. Reactive, if you think about it, it just means that the fetus's heart rate is reacting appropriately to movement, meaning that it is accelerating by at least, and we have specific parameters, so it's accelerating by at least 15 beats per minute, lasting for 15 seconds. So about 1.5 of those little boxes on the fetal paper, on the EFM paper, okay? And it only needs to do that 2 times though, okay? So reactive, this is the definition, and you need to memorize it. This is a major foot stomper. I will ask you something in terms of patient teaching or follow-up. I don't even know yet, but somewhere this is going to be a question. So non-reactive, much less important. Well, I guess more important in another way. It means that the above criteria has not been met. Okay? So now, what do we do with those results? If it's reactive, remember, this is the good one. This is what we want. we conclude the test and reschedule if necessary. Sometimes an NST might be a one-time thing because a mom calls and says, I don't think my baby's moving as much. You have them come right in to the hospital, the triage, your clinic, whatever the procedure is. You do an NST and you conclude it and it's reactive. And you just instruct them, call if anything changes or, they feel that they're worried again. But you don't necessarily have to schedule one. But in certain cases with high-risk patients, as I mentioned before, they may be having one of these every day, every shift while they're in the hospital. Even as outpatients, they may be coming in 2 to 3 days a week to have an NST. So when it's going to be rescheduled, I cannot tell you. Now, if it's non-reactive, we need to try to do some things to make it reactive. The usual cause of it being non-reactive is that the fetus is not moving. And because the definition is related to what the fetal heart rate does with movement, then we need to have the fetus moving. So there are a couple of different things that we can do to wake the fetus up. First of all, we can extend the time, from 20 minutes, extend that by 40 minutes if necessary, and we can wake it up by using a vibroacoustic stimulator. The vibroacoustic stimulator sends a sound wave in that can wake the fetus up because they do have sleep and wake cycles. And you can apply this device on the abdomen near the fetal head for 3 seconds at a time for a maximum of 3 times. And if that does not cause them to wake up, then you have to move on, notify the healthcare provider and move on to other forms of testing, most likely which will be a biophysical profile. Other ways that we have seen practices try to quote-unquote wake up a fetus is to give mom something sugary to drink, such as 4 ounces of orange juice or something of that nature. It's absorbed very quickly, so you get a rapid response in the blood sugar, and that usually wakes a fetus up. You could also use some physical manipulation, palpation on the fundus as well. This is a picture of a reactive NST strip. So this is good. When you're looking at an NST, the first place you want to look is at the bottom where the markings are for fetal movement. That's what this is. This little blip here says FM. Every one of these are fetal movement. This might be different than some other strips that we evaluate, but in an NST, the first thing you want to look at is movement, because without movement, you have nothing to compare, because this whole test is about what does the fetal heart do with movement. So we identify our periods of movement. And then the second thing we look at is the fetal heart, and do we see accelerations? Remember the 2 things that tell us that the fetus is doing well? The 2 parameters we like to see on an electronic fetal monitor strip. Do you remember what those are? That's right, accelerations and variability of the heart rate. So in this case, we look from the fetal movement directly up to see if we have it. Now, if you remember your definition, you only have to have 2 of these in 20 minutes. So this strip obviously looks great. And for some reason, I cannot draw a straight line. There's not one there, but that's okay. Every other one besides that has one. So if you remember, each one of these little boxes like that, each one is 10 seconds. So we would expect an acceleration to at least cover about that much, right? So you can kind of eyeball it. Here's a whole box plus almost that one and part of that one. So is that 15 seconds? Yes. Here's one. It's got 2 boxes. So that covers. Here's one that's got 1, 2, 3 boxes. So you can see how you count that here. 1, 2, 3 boxes. So that tells us that it's lasted for at least 15 seconds. But remember, it's got to be 15 by 15. 15 beats a minute elevated and lasting for 15 seconds. So if we think that the baseline, and I would just draw a line kind of like this is the baseline, right? So now we're looking to see if these accelerations go up by 15 beats. This baseline is 120. So this is 120. This line you can barely see right here is 130. This is 140, and this is 150. So if we're saying the baseline's about 120, we want to go to 135. But look, most of these are up past that. So 15 by 15 has been met here at least 5 times. So this is a reactive NST or good. Why? Because it has at least 2 accelerations during this testing time that go up 15 beats a minute and last at least 15 seconds. That's reactive, that's good, that's a wonderful thing. Now this is an example of a non-reactive NST. This almost has that straight line look. This is a fetus who's kind of calling for help. It is moving. You can see that here. It has plenty of fetal movement in this period of time, but we don't see any accelerations. So this heart rate is not accommodating when the fetus moves. Because remember, when we have a reactive NST, the basic phrase that we use or the terminology is that this fetus has adequate oxygenation and that the neural pathway in the central nervous system to the heart is intact and healthy. So that's what a reactive NST means. Adequate oxygenation and a healthy neural pathway between the CNS and the heart. So if that's what a reactive means, and non-reactive means they may not be adequately oxygenated and they may not have a healthy neural pathway from the CNS to the heart. And so that's concerning. That's going to cause us to do further examination of the fetus. This is an oxytocin challenge test or a contraction stress test. I'm not going to include this on your exam. I hope that if you saw this, you might be able to figure out what it is. The reason I'm not going to include it is because you just don't see them anymore. And the reason you don't see them anymore is because it can cause false results. Negative results, okay, can give you reassurance, but it has about a 50% chance of giving you the wrong result. And so a plan of care based on results that are wrong 50% of the time are not good enough in 2017. We tend to rely on the results of a biophysical profile, which statistically are much higher. So I'm not going to ask you test questions, and I hope that doesn't come back to stress us out. But basically, you know, we try to get contractions and see what happens to the fetal heart. But again, about 50% of the time, the result that we get is wrong. So you're really probably not going to see this in your future. So you see I'm Xing these off. So when I put your exam together for next week, those won't be on there. Okay, so here's a question for you. What is appropriate patient teaching related to maternal serum alpha-fetoprotein analysis? Abnormal MSAFP levels should be followed by more specific tests. High MSAFP levels are usually associated with chromosomal abnormalities. Having MSAFP testing will eliminate the need to do an ultrasound exam, or the initial MSAFP testing will be performed at 12 weeks of gestation. So which one of those do you think is the correct answer? If you picked A, abnormal maternal serum alpha-fetoprotein levels should be followed by more specific tests, then you picked the absolute correct answers. Of course, we know that 2 is incorrect because it's not high levels that are associated with chromosomal abnormalities, but low levels. And it will not eliminate the need to do ultrasound exam. It will probably cause it. Okay? And the initial MSAFP testing will not be done at 13 weeks. It will be done more likely at 15 to 17 weeks. So the biophysical profile is a fetal surveillance test that gives us a pretty good accurate picture of what's happening with the fetus, because it's taking a lot of different pieces of information and putting them together and then basing a plan of care on that. The purpose of this is to look at these 5 different variables, these different markers, and determine pretty accurately whether the fetus is in any jeopardy in terms of oxygenation. The 5 variables that are considered in a biophysical profile are, as you can see here, fetal breathing movement, fetal movement of body and limbs, fetal tone, amniotic fluid volume, and an NST. The first 4 variables are all obtained via an ultrasound. So these are not tests that are performed by the nurse. These are tests that are performed by the sonographer. The NST is performed by the nurse. Each one of these categories in terms of scoring receives 2 points if they're perfect. So sort of similar to the APGAR scoring. So each one gets 2 points if they're perfect. So that makes a total score, perfect score of what? 10. Different from the APGAR scoring is that if they do not meet this, they get a score of 0. So the scores can only be positive numbers, right? Because you can get 2, 4, 6, 8, or 10 points, but there are no ones. If you have fetal breathing movement, you get 2 points. If you don't, you get a 0. If the fetus moves body and limbs, they get 2 points. If they don't, they get a 0. If they demonstrate fetal tone, they get 2 points, and if they don't, they get a 0. If they have an adequate amount of amniotic fluid, they get 2 points, and if they don't, they get a 0. If their NST is reactive, they get 2 points, and if it's not, they get a 0. So a perfect score is 10. Now, you can be familiar with these 5 variables because this is what is included in a biophysical profile. Exactly the measurement of it, I don't think you need to know. For example, fetal breathing movement, you can look in your body. That means that they should have at least one movement lasting for 30 seconds or more within the 30-minute of testing. So this sonogram may last for 30 minutes. That causes a lot of anxiety because the reason that anybody is having a biophysical profile is on a weekly basis or a bi-weekly basis or maybe an every other day basis because of some high-risk problem or some newly suspected problem with them or their fetus. So just having the biophysical profile can be pretty nerve-wracking for most people. So we do need to know that the 5 variables are fetal breathing. Now, does a fetus breathe in utero? No, they do not breathe in utero, meaning they do not exchange oxygen and carbon dioxide by breathing using their lungs. However, they do make lung movements, and it's important that they have these practice breaths in and out, and again, at least one in a 30-minute period of time. As far as fetal movement itself goes, that's just moving in the body, gross movements. It can be trunk movements, so they're just kind of moving around. It can be a limb, but they're moving, their trunk or their limb, and they need to do that about 3 times in 30 minutes. Not any specific one, not any specific order, it can be any, just like 3 movements. But on fetal tone, it does get very much more specific. They need to have at least one episode where one of their limbs goes from a flexed position to an extended position and then back to a flexed position. And that's very important. And then, of course, the NST will contribute that score. So what happens with that score really depends on the gestational age of the patient and all of the other history. But generally, I can tell you that a score of 8 to 10 is pretty much considered perfect, and that's okay. Of course, a score of 4 or less would not be very reassuring. Probably that patient is going to have a delivery soon, today, either by induction or cesarean, again, depending on the rest of the patient's history. But that's not a normal score. less than 4. I'm sorry, not 4, but less than 4. So that leaves 4 to 6. So if we have 8 to 10 is good and 0 to 2 is no good, what is 4 to 6? Well, that's in the middle. And it really depends. And thankfully, that's not our job to decide. There is a chart in your book on page 312 that is not in your notes, and I would like for you to look at that. It has to do with what are the signs of hypoxia in the fetus and which one occurs first. So as the fetus is experiencing hypoxia, what do we see as the first sign? And then as that hypoxia continues, progresses, lingers, etc., in terms of fetal assessment testing, what do we see? So if you refer to that page that chart on 312, figure 15-11, you'll see that the first sign that we see of hypoxia is a late deceleration. And we discussed that just on our switch day yesterday. So that's one of the first signs that we see. Next, we'll see that the accelerations disappear. So that was one of our 2 signs of fetal well-being. Hence, when I mentioned yesterday that when we see late decelerations in combination with absence of accelerations, we are more concerned. And that's because now we know that hypoxia is continuing and or progressing. And when that continues, if you look on the right-hand side of figure 1511, you'll see that the pH is going down. After that, accelerations disappear, we'll be able to see some of the parameters of the biophysical profile that will be missing. The first thing that we see is that fetal breathing movements will stop. Then we see that fetal movement ceases. That's a very late sign. So any fetal movement will not be present. And that's because the fetus is hypoxic, and just like if you were hypoxic, you'd like sit still. If you were short of breath, one of the things you'd do would be like sit still, don't move. And that's sort of like what the fetus is doing. And so that's not a good sign. And eventually, if you didn't have enough oxygen, if you think about it, you'd pass out. Well, that's kind of sort of what the fetus looks like when the fetus is compromised, meaning that the fetal tone is absent. So again, please look at and be familiar with that figure 1511 on page 312. The last topic of conversation is the assessment of fetal movement. As you can see here, fetal movement is a reassuring sign. When fetuses move, moms are happy, makes them happy. In fact, it's one of the danger signs is absence or decrease fetal movement. So we teach our patients to, just be cognizant of the fact once their baby starts moving. And how long before they can feel those movements? That's right. Quickening is first, and that's between 16 and 20 weeks. Again, doesn't occur any different time with women who are having subsequent pregnancies, but they have felt it before, so they're a little more in tune to what it feels like. So sometime between 16 and 20 weeks is normal. So it's one of the things that we assess on our patients, and we ask them to tell us if there's a change in the fetal movement. I will tell you that many of you probably during your pregnancy were not asked to keep track of your fetal kicks, other than the general questions about, is your baby moving? Do you feel your baby moving? Is your baby kicking? Those kinds of things. Because once we ask them, a woman, to start counting her fetal movements, then there's something wrong. And that makes a mom definitely anxious. This quote that's here is significant. It says, maternal reporting atypical changes in fetal activity has shown to be as valid as formal counting and documentation of fetal movement. I'm hesitant to ask you to memorize the numbers that are in your textbook because they are not always the same. And I think if we just remember this statement in terms of NCLEX and big tests in the future and little tests in the future, that will be okay. You can read in your book, it gives some very specific numbers. I just don't think that that's going to be on an NCLEX exam for a general nurse graduate. So let's just recognize that fetal movement is a sign of fetal well-being also, and that a change in that can be a reportable event, and that according to research shows that just a change that's different, what the mother is used to feeling, is as valid as sitting down, laying down an hour after dinner for 30 minutes and counting kicks or whatever the procedure might be. Okay? Okay. And that concludes chapter 15. As always, if you have any questions or need clarification, please let me know. Good luck. See you Wednesday. Have a happy and safe 4th of July. God bless America.